Hello class, this is Professor Teal here, and I wanted to provide you with a quick overview of the ICD-10-CM official guidelines for coding and reporting. And you should see those here on my screen. Now, the coding guidelines, it's very important that you become familiar with them, and we always say in coding, guidelines, guidelines, guidelines. You must always follow the coding guidelines. These guidelines are actually located in the front section of your ICD-10-CM codebook, so you have them there to refer to. If you would like a separate copy of these guidelines, you can simply Google ICD-10-CM official guidelines for coding and reporting, and you will be able to find a PDF version, which is what I have displayed here. This is actually a PDF version. And I actually like having the PDF version available simply because, as you can see on the margin, I can point and click and jump to various sections easily rather than flipping through the book. So when I'm looking for something specific, it's just helpful for me to be able to click and jump around. And also you can use the magnifying glass search feature if there's something specific that you're looking for. So it's just kind of a handy thing to have available to you. Now, these guidelines have been approved by the cooperating parties, and you might hear us say that, the cooperating parties. There's actually 4 organizations that make up the cooperating parties. That is mentioned right here in this paragraph. Those 4 organizations are the American Hospital Association, the AHA, the American Health Information Management Association, which we know as AHIMA, the Centers for Medicare and Medicaid Services, or CMS, and also NCHS, the last one, and that is the Center for Health Statistics. So they're the ones that provide the guidelines, but one caveat is that while these are official guidelines, they do not take precedence over the instructions that's provided in the actual code book itself. So you see here the instructions and conventions of the classification take precedence over the guidelines. And what that means is when you're becoming more familiar with your code book, you'll notice that there are some instruction notes and things of that nature. Excludes 1 notes, excludes 2 notes, code first notes. So the instruction that's provided as part of the actual classification, what they're telling you is that supersedes the guidelines. And there should never be a conflict, but just in case there is, they did put that little tidbit here and there. So what I'm in right now is just the intro section. And I'm not going to read this. I'm going to let you guys read through it at your own leisure. Following the intro is the table of contents, and what I'd like to cover in this video, I'm not going to cover all of the guidelines. As you can see, it's 120 pages long here, but what I'd like to do is just go over some of the basic, what we call the coding conventions. And that's pretty much the how-to, the rules of the road, the how to apply certain terminology or definitions, and really how to get started with coding. You have that followed by general coding guidelines, and general coding guidelines are applicable to all of your ICD-10-CM coding. Beyond that starts the chapter-specific coding guidelines, and that is the piece that I am not going to get into today. What I suggest is, as we cover a specific chapter of ICD-10-CM, it is arranged by chapters. There are 21 chapters. Your textbook chapters are not necessarily the same. So when I say chapter 1 of ICD-10-CM, I'm referring to chapter 1 of your actual code book, not your textbook, but the actual ICD-10-CM coding manual. So whatever chapter that corresponds to in your textbook, when we happen to cover chapter 1 of ICD-10-CM, come here and review the chapter 1 coding guidelines. Same when we cover Chapter 2, then come here and review the Chapter 2 guidelines. It's easier to take it in little pieces like that rather than trying to review them all on the front end. So let's get started with some of the basics. I'm going to go to Section 1, Coding Conventions and Guidelines. And this basically tells you how to use your code book, you know, what the layout is, what the format and structure of actual codes are, what the codes are used for. So for those of you that may never have had exposure to medical coding yet, there are just some basics of getting to use your code book that I want to cover right now. Your code book itself is comprised of two main sections. You have the alphabetic index, and that's actually up in the front of the code book. And that is followed by what we call a tabular list. And that's the back portion of your code book. So it's divided into two sections, the alphabetic index, the tabular list. As a coder, what you're going to do is you're always going to start in the alphabetic index. That's where you begin by looking up your main terms. And then when you find what it is you're looking for, you're always going to then go to the tabular list under that particular code category, and you're going to confirm your code selection, ensuring that you've used all applicable characters. ICD-10-CM codes can be anywhere from 3 characters long to 7 characters long. And the index does not always provide you a full 7 characters. Sometimes you have to go over to the tabular list to select the rest of your characters. So anywhere from 3 to 7 characters. So the format of codes, as we're mentioning here, the first 3 characters is what we call the code category. And you may have a code where 3 characters is actually a complete code. I-10 is a good example of that. That's the code for hypertension. It's only 3 characters long, and that is a full and complete code. Other codes may be all the way up to 7 characters. So anywhere from 3 to 7 characters may be a valid code. After the first 3 characters, when you have more than 3, you will have a decimal place. So it'll be 3 characters, a decimal place, and then up to 4 more characters. It's important when you're writing out your codes or you're typing them in for your assignments or your quizzes, do not leave that decimal point out, because then your code is incorrect. It's part of the required formatting, and I do realize that when you are using encoders and stuff, it tends to drop it, and that's because it knows that the system, it's dropping these codes automatically into an electronic billing system, and it's maintaining the format there. So they're not always shown on screen, but if you aren't following proper formatting, it's a bad habit to get into. You're going to be marked wrong on your certification exams if you do that. You won't be able to distinguish sometimes between an ICD-10-CM code and an ICD-10-PCS code, because they're going to look identical, and they might even have the same characters, or an ICD-10 and a CPT code. So formatting is just, it is an important thing to remember. So don't leave your decimals out. It's a bad habit to get into, as I mentioned a moment ago. So anytime there's more than 3 characters, it'll be 3 characters, a decimal point, and then up to 4 more for a total of 7 max. We have a concept of what we call a placeholder X in ICD-10, and what that does is it allows for future expansion. And where you're going to see this most often is when we get into code categories that require a 7th character, but you only have less than 6 characters leading up to that 7th character, you fill in the blanks with an X, because the 7th character must always remain in the 7th character position. And I know it seems funny to cover this on the front end when you don't know what we're talking about when we say 7th characters, but there are fractures, for example, where you have to indicate the episode of care as the 7th character. So is it an initial encounter? Is it subsequent? Is it a late effect? So that's what I mean when I say the episode of care. And because that's a 7th character, it has to stay in that 7th character place. So you would put those placeholder character X for any of the blank spaces leading up to the 7th character. There's also places where there's simply an X built into the code because the classification system itself, ICD-10-CM, has left that there for future expansion. So there's nothing that they need as far as characters today, but in the future, they suspect that we may need additional specificity on a code. So they've got some X's there just to allow for some future expansion. You're not going to see that too often. Most often where you're going to see that placeholder character is when you're using a 7th character and your code leading up to that is less than 6. Now there's some abbreviations or terminology, punctuation, that sort of thing that you need to become familiar with in order to understand your code book and how to use it and how to distinguish between things like areas where there's just a term that the provider has used that is a non-specific term versus we actually have a specific term that the provider has used, but we don't have a specific code for it. And those are two different scenarios. And so one of those is what we call NEC, not elsewhere classified, and one is NOS, not otherwise specified. So some of your codes might actually say NEC, and some of your codes might say NOS. And it's important that you understand the difference between these two when you're trying to make a choice. NOS, not otherwise specified, that means that the documentation just did not specify. It's an unspecified condition. So for example, the provider has just stated pneumonia. That's all they've given you. And we have all kinds of codes in the code book for pneumonia for specific types of pneumonia, but you just don't have that information in the medical record. So that's an NOS, a not otherwise specified, or an unspecified code. NEC means that the provider has given you the details, but there just isn't a code available for the condition at that level of specificity. So this is your other specified. So NOS was unspecified, NEC is other specified. Moving along, we have some punctuation that you're going to need to be familiar with. Whenever brackets is used in the alphabetic index, that's to indicate a manifestation code, and the code that is in brackets is always going to be your secondary code. So this is a sequencing indicator for you. Parentheses is used to enclose non-essential modifiers in your alphabetic index. And what a non-essential modifier is, that means that the presence or absence of the term being used does not change your code selection. It's kind of like a take it or leave it. Your code will not change if that term is there or not there. So for example, if they say acute appendicitis, and I'm just using this as an example off the top of my head, but let's just say you looked up appendicitis in the alphabetic index and the term acute was in parentheses. What that means is you don't need acute specified in the documentation in order to use that code. And even if acute was in the documentation, it wouldn't change the code because the default was just the term appendicitis, and that's going to be the same code whether it's specified as acute or not. I don't know if that's an accurate example because, you know, without going to the index right now to see if acute is listed as a non-essential with the term appendicitis, you know, I was just throwing that out there as an example. And you'll see these non-essential modifiers all over the place. Again, if it's a term that's listed in parentheses, you don't have to have that specified in order to use that code because that term is not going to change your code. Okay, so for the use of and, it's going to refer us to a different guideline. So we're going to just scroll right past. Other and other specified, we talked about the abbreviation NEC. Unspecified, we talked about NOS. Includes, this note appears after a code category, basically to say that here are some examples of what this category includes. So just like it sounds, includes note, that's what it means. Inclusion terms. List of terms is included under some codes. These terms are the conditions for which that code is to be used. The terms may be synonyms of the code title, or in the case of other specified codes, the terms are a list of the various conditions that are assigned to that code. And the inclusion terms are not necessarily exhaustive, so it's just a sampling. Just because you don't see it listed there doesn't mean that that particular code is not applicable. Additional terms found only in the alphabetic index may also be assigned to that code. So trust the index is what that's telling you. Now there are two types of excludes notes with ICD-10-CM. You have excludes 1 and you have excludes 2. And the easiest way to distinguish between these two is when you say excludes 1, you're only going to be using one code. When you're saying excludes 2, it actually may be appropriate to use 2 codes. And so for me, that's the easiest way to keep these two straight in your head. So let me give you an example here. Excludes 1, if there's a note, you're looking up a code, and it says excludes 1, and it lists terms that are excluded. What that means is that those conditions are not coded here. So the code that you're looking at excludes these other conditions. And if what you're really needing is one of those other conditions, you're going to go over there and code it instead. So it's only one code. You use either this code or you use that code, but you never use the two codes together. Now, excludes 2, on the other hand, say you look up a condition and it leads you to a code, and then there's an excludes 2 note with a list of other conditions. Excludes 2 means those other conditions are not included in this code you're looking at, but the patient may actually have both conditions at the same time. And what it's telling you is that you need to use both codes because that other condition is not included here. So it's not included here, but you code them both together. So that's where you end up with 2 codes. So excludes 1, not coded here. You either use that code or you use this code. And a good example of the excludes 1 is congenital conditions and acquired conditions. You wouldn't use them both at the same time. The patient either has the congenital form of that condition or they have the acquired form. And so if you happen to be looking up that condition and you look it up as the acquired form and there's an excludes 1 note that has the congenital form, and you discover, oh wait, this patient actually had the congenital form, I need to go there instead. You wouldn't code the two together. They either have one or they have the other, but they don't have both. So that's the best example of an excludes 1 that I can give you. And then, like I said, excludes 2 means it's not included here, but it might need to be coded as well. So you might use 2 codes if appropriate. So 1 code versus 2 codes, excludes 1 versus excludes 2. Etiology and manifestations. So this is your cause and effect type of conditions. Some conditions have both an underlying etiology and multiple body system manifestations that are caused by that underlying etiology. And in those scenarios, ICD-10 has a coding convention that requires you to code the underlying condition first. So this gets to those brackets we mentioned earlier. That underlying condition will be listed and it will have a manifestation code listed in brackets beside it. And you're going to use both, but for the sake of sequencing, the manifestation must come second. So you have to sequence the underlying condition first and the manifestation code second. And there's often terminology in the book that helps you with your sequencing. So if you're looking at a condition and it tells you code first, such and such, that is a sequencing that's telling you that other condition has to be coded first before the one that you're looking at. Now, when it says use additional code, that means you're going to use an additional code for that other condition. So that's not telling you that it has to go first. So there's a difference between those two. So take the time to read through this. You see it's quite lengthy, so I'm not going to read it all. The term and is interpreted as either and or whenever it appears in a title, and that's an important concept because if you see and, you have to know to interpret it to mean either way, and or, because otherwise you might be looking for both of those things to be present in order to code it. And that's not necessarily true when it says and. It could mean and or. So for example, cases of tuberculosis of bones, tuberculosis of joints, and tuberculosis of bones and joints are classified to A18.0, tuberculosis of bones and joints. And so it could be either the bones or the joints, but it's classified to that section of bones and joints, okay? The term with, the word with or in, whenever you see that under the alphabetic index as a subterm, it should be interpreted to mean associated with or due to when it appears in a code title or an instructional note in the tabular list. And so what that means is if you see it listed as with, so hypertension with heart disease, when you see it listed that way in your alphabetic index or your tabular list, that means that the classification is assuming a cause and effect relationship between those two. It links them, okay? And so this is an important concept as well. It might affect how you use certain combination codes. So pay attention to that and come here and refresh on this guideline if need be. See and see also, that is a cross-reference that you're going to find in your alphabetic index. And what it's going to do is it's going to refer you elsewhere in the index. Now, when you see the word see, that means you have to actually go over there for the correct code. It's redirecting you. When you see also, it's saying that there's another main term that may also be referenced that may provide additional alphabetic index entries that may be useful. So see also is a maybe. You don't always have to go there. You may or may not find what you're looking for in that other location. So see is a complete redirection. You must go to the other location. See also is, hey, there might be some additional information over here that might be more applicable to your scenario, so go check it out. It's a maybe. Code also, this one is, we talked a minute ago about code first and use additional code, and those ones are absolute sequencing guidelines. When you see code first, that other condition must be coded first. When you see use additional code, that additional condition gets listed second. So those are absolute sequencing guidelines. But whenever you see code also, there's no sequencing guidance here, okay? The sequencing depends on the circumstances of the encounter. It's just telling you, hey, if the patient also has this going on, make sure you code that as well, but it's not telling you which one has to go first. Whichever one goes first is going to be based on the circumstances of the encounter. And if it's an inpatient encounter, you have to follow the definition of principal diagnosis to decide what gets listed as first. And if it's an outpatient, you have to follow the guidance for your primary or first listed diagnosis. So the circumstances of the encounter will govern which one comes first. The concept of a default code, all this means is that for some conditions, when you look the term up in the alphabetic index, right beside the term there is a code, and that's what we consider a default code, meaning that without any additional details, that would be the code that you use. It's the default, so just like it sounds. And then lastly, we have this mention here about provider documentation. And what this is telling you is that the assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient. Code assignment is not based on clinical criteria used by the provider. So we're not questioning their judgment. We're not going and looking to see if what they stated is actually supported by test results and labs and that sort of thing. If they say the patient has a condition, then we take that as sufficient enough and we assign our code based on that. Okay, so that's some of the basics. Those are your basic coding conventions, and I know I covered that rather quickly, but you have these guidelines available to you. Go back and read them in detail, and some of it will make more sense as you're actually learning a little bit more about coding. But it's just an important reminder that these guidelines exist and to know what they cover. So go back and review them as needed. That's the basic conventions. And then we get into section 1B, which is your general coding guidelines. And this is basically telling you how to locate a code in ICD-10. To select a code in the classification that corresponds to a diagnosis or reason for visit, first locate the term in the alphabetic index and then verify the code in the tabular list. So that last part, verify the code in the tabular list, that is very important. Never code directly from the alphabetic index. You always must verify your code in the tabular list. And part of the reasoning for that is this next sentence: read and be guided by the instructional notations that appear both in the alphabetic index and in the tabular list. So the excludes notes, for example, that we just mentioned, excludes 1 and excludes 2, those are not present in your alphabetic index. You have to go into the tabular list before you see those kind of instruction notes. Your code first, your code also, your use additional code, those sorts of things. So you always go to your tabular list to verify your code. It is essential to use both the alphabetic index and the tabular list when locating and assigning a code. The other thing is that the alphabetic index does not always provide the full code. And what you're going to see is you're going to see a dash. So you might see character 1, character 2, character 3, and a dash. And what that means is you need to go over to the tabular list to complete the code, to finish selecting your choices based on what's relevant to your case. And so whenever you see a dash, that means you are not at a final code. It's not valid the way it is. You need more information. Some go all the way to 7 characters and some, are less than that. But if you use less than what's actually required of the code, then your code becomes invalid. And that means this piece, this next sentence right here: diagnosis codes are to be used and reported at their highest number of characters available. Okay, and so let me just, I have some PDF versions of the alphabetic index and the tabular list, and so let me just show you right quick what I mean. I'm going to hop on over to here. And you have your code book, and this is not the prettiest version because it's a PDF, but the point there is this: you see this A02, that's your category. That is not a valid code. It's not a complete code. And the reason that I know that is because of what's indented below it. I could select A02.0, and that is a valid code. That is complete. I can use that as is. I can use A02.1, and that's a complete and valid code. I cannot use A02.2. That is not a valid code. And the reason I know that is because, look, there's some greater specificity here. There's some additional characters that are indented below that. So A02.2 is not complete. I need to select my appropriate fifth character before I have a complete code. And that fifth character might be a 0, might be a 1, might be a 2, might be a 3, 4, 5, or 9, depending on my documentation and what it actually specifies. I have to select one of these. So you always have to pay attention to that. And your code book should have some symbols next to it when you're in your tabular list. Depending on what publisher you're going with, they're basically different flavors of the same book. So the symbols and the coloring and that sort of thing might be a little bit different, but they essentially all contain the same information. So how they reflect an additional character is required might vary from publisher to publisher. There might be a little checkbox that says check fourth, meaning, you know, check your fourth character, you need to add something else, or check fifth character. Whenever you see a symbol like that, your code is not complete. And so that's what we mean when we say you have to select the code to the highest level of specificity. That highest level of specificity may be 3 characters. So I-10, I gave you that as an example, is a complete code. A02 is not a complete code because, look, there's stuff indented under it. So I know that's not a complete code. So that's what we mean. And you can use codes basically throughout the entire code book. That's what this is telling you. The appropriate code or codes from A00.0 through T88.9, and then your Z codes must be used to identify diagnoses, symptoms, conditions, problems, complaints, etc. You know, I don't know why they need that guideline, because obviously you have that whole range of codes in the code book, so any of those would be appropriate to use. This next concept, signs and symptoms, this is one that can be a little bit confusing for new coders. And this goes along with this next one, the next two actually. So signs and symptoms, conditions that are an integral part of a disease process, and then conditions that are not an integral part of a disease process. These 3 guidelines go together. And basically, what all of this means is that it's okay to code signs and symptoms if you do not have a definitive diagnosis, or if these are signs and symptoms that are not an integral part of that definitive diagnosis. So let me give you an example. A patient presents with a chronic cough. They've been coughing for the last couple months. It's not going away. They don't seem to be getting better. The provider is going to run some tests, ordered a chest x-ray, and is going to have them return to the clinic in a week to follow up on these test results. So at that point, all we have to code is that chronic cough. It's a symptom, that's all we have to code. And it's appropriate to code it that way. Now, the patient has cough, congestion, shortness of breath, they've been wheezing. The provider runs a chest x-ray and determines that they have pneumonia. Because we now know the patient has pneumonia, it is not appropriate to code the cough any longer. We're not going to code the cough. We're not going to code the shortness of breath. We're not going to code the wheezing, because those are all an integral part of having pneumonia. Those are the symptoms that accompany pneumonia. So you're not going to code those separate. The only thing you're going to code is the pneumonia. There are signs and symptoms that might be completely unrelated, and it would be appropriate to code those. So let's just say that the patient has pneumonia and they're also experiencing chest pain, and the provider has indicated that the chest pain is not related to the pneumonia. It is a symptom, but it's not related to pneumonia, so you can code it separately. And hopefully we would have something a little bit more specific than chest pain. Maybe they have angina going on or something like that. But just to give you an example, if it's something that's unrelated or not an integral part of a disease process. So maybe there is blood in their sputum. You know, not everybody that has pneumonia is going to be coughing up blood. that's something that's a little bit more serious. There's something else going on there. So you would indeed code that separately. It's not an integral part of the disease process. So that's what these three mean. You can code signs and symptoms if needed when they are either all you have to go by, or they're completely separate and not related to your definitive diagnosis. You never code signs and symptoms that are an integral part of the disease that you're coding or the condition that you're coding. And then multiple coding, this is just telling you, basically it goes back to the whole thing about manifestations and underlying conditions. You might need multiple codes to fully capture the condition, or if you see any instruction notes that say code first, code also, use additional code, you might need more than one code for a single condition. And that's all that this is telling you. So I'm going to scroll through that. Acute and chronic conditions, if the same condition is described as both acute and chronic, and there are sub-entries in the alphabetic index for both at the same indentation level, then you will actually code both. You'll assign one code for the acute, one code for the chronic, and it tells you to sequence the acute code first. So it gives you some sequencing guidelines there. Combination codes, that's a single code to capture all aspects of a condition. And so one combination code is all that's needed to capture all of that. That's what we call a combination code. You don't have to use additional codes. But then it tells you here at the very end, when the combination code lacks necessary specificity in describing the manifestation or complication, an additional code should be used as a secondary code. So you'll add a little bit of detail with a secondary code. Sequela, all that means is late effect. So whenever you see the term sequela, that's what we mean. It's a residual or late effect. With late effect coding, there's no time limit. A late effect is a late effect. It doesn't matter how late after the fact it appears or how long after the fact it lasts. It could be years later. It can be coded as sequela. Impending or threatened condition. Code any condition described at the time of discharge as impending or threatened as follows. And then it gives you some guidelines here. Since it says at the time of discharge, that means that this is a guideline that's going to apply to your inpatient setting. Reporting the same diagnosis code more than once. For those of you that may have been exposed to CPT coding, you know that you can list a CPT code more than once if it was performed more than one time, because they need to be they need to get reimbursed for the multiple occurrences. But with diagnosis coding, it's not the same concept. You only use the code one time. If there's no distinct code, you don't, So laterality is a good example, and they gave that example here in this one. This applies to bilateral conditions when there are no distinct codes to identify laterality or two different conditions classified to the same ICD diagnosis code. You only report it once, because reporting the same code twice, once for the left and once for the right, even though the code doesn't specify right or left, it adds no detail to the person that is receiving that code, because there's no difference between those two codes. If it's the same code, it's the same code. It doesn't matter how many times you list it, you're not telling more to the story. So if each unique ICD-10-CM diagnosis code may only be reported once for an encounter, you don't list it multiple times, even if you're trying to capture multiple conditions, because the detail simply isn't there if you're using the same code. With regards to laterality, one thing with ICD-10 is that they greatly expanded the classification system, and a lot of that had to do with laterality, expanding the codes so that they would reflect right versus left versus bilateral. And so many conditions are reflected with a code that says bilateral. And if the patient has it on both sides, you use the bilateral code whenever that code is available. However, if there is no bilateral code, then it is appropriate to assign separate codes for both the left and the right. And your code will be different. So this is not reporting the same diagnosis code more than once, because your character will be different towards the end, because one will reflect right and one will reflect left. So it's telling you use bilateral code if it's available, and if not, code it on both the left and on the right. Here we have a documentation guideline. Code assignment is based on the documentation by the patient's provider. And by provider, they mean physician or other qualified healthcare practitioner legally accountable for establishing the patient's diagnosis. So this might be an MD, it might be a nurse practitioner, it might be a physician's assistant, anybody that is a qualified healthcare provider legally accountable for establishing the diagnosis. So these are not nurses, okay? These are your clinical providers that have the scope of practice for this, okay? And then it goes on to tell you though, however, there's a few exceptions. So there are some cases where you can code based on documentation by nurses or other clinical support personnel. So here's the few exceptions. Body mass index. So anywhere where you see the BMI documented, you can pull that information for your code selection. Depth of non-pressure chronic ulcers, pressure ulcer stage. So in this case, the depth is what we're talking about, and you'll need that for staging when you're selecting your codes. The nurse is not the one that's diagnosing the patient with the pressure ulcer, because the qualified healthcare practitioner should have stated that the patient has these ulcers, but what you're getting out of the nursing or the wound care nurse is the depth of it. So you're just getting the detail from the nurse's note. The coma scale and the NIH stroke scale codes, code assignment may be based on medical record documentation from clinics who are not the patient's provider. I.e. physician or other qualified healthcare practitioner legally accountable for establishing the diagnosis. We just talked about that definition. And it's saying, since this documentation is typically documented by other clinicians involved in the care. So for example, it's telling you that the dietitian often documents the BMI. So it's okay to get the BMI from the dietitian's their note, the nutritionist or whatever. A nurse often documents the pressure ulcer stages. The EMT technician often documents the coma scale. So, and then it's telling you what I just said a moment ago, the associated diagnosis. So the fact that the patient is overweight or obese, the reason why we need the BMI, that comes from the patient's provider. So they've given you the diagnosis. Now you're just going over here to get the additional detail. All right, so let me go ahead here. I'm going to scroll through some of these. Again, I want you guys to come back and read through these on your own and make sure that they make sense. I'm just kind of trying to highlight some of these ones that I know are things that are either hard for new coders to grasp or things that they often forget. Borderline diagnosis. If the documentation says borderline, fill in the blank, at the time of discharge, then you code it as if it were confirmed, unless the classification provides a specific entry. So for example, borderline diabetes, it's telling you that there's actually an entry for borderline diabetes. So you use that instead. You don't code it as if it exists. But if there's not a code for borderline hypertension, borderline diabetes, you have to first look it up in the index to see if there is such term. If there is, you're going to use that, and if not, you code it as if it existed, is what this is telling you. And since it says at the time of discharge, again, this would be an inpatient thing. Use of signs, symptoms, and unspecified codes. We covered that. Again, it's telling you if a definitive diagnosis has not been established. So this is just another reminder. All this stuff here in bold, the reason it's in bold is because these are new additions to the coding guidelines. And it's interesting that they've added a coding guideline here for encounters in hurricane aftermath. And I happen to live in Texas, and so, you know, we've had some hurricanes that have come through and done some great devastation. And so it's just interesting to see how these things come about. So it's basically telling you an external cause of morbidity code should be assigned to identify the cause of the injury incurred as a result of the hurricane. External cause of morbidity codes are never to be recorded as the principal diagnosis or first listed in non-inpatient settings. The injury code always gets sequenced first, but they want you to assign an additional external cause code. And then it's some sequencing of external causes, other external causes. So all these external cause guidelines are new. And same thing, use of Z codes. Because it's in bold, that's how I know that it's new. Z codes may be assigned as appropriate to further explain the reason for presenting for healthcare services, including transfers between healthcare facilities. And it gives you some of the Z code categories here. And that is the end of the basic coding conventions and guidelines. We covered section 1A and section 1B. Let me collapse that, the general coding guidelines. See, 1A, 1B. And then next is 1C, which is your chapter specific coding guidelines. And again, I want you guys to review those as these chapters are covered in your actual textbook. Then you're going to come back here and review the chapter specific coding guidelines. Before I conclude, one thing that I do want to mention is that, and let me collapse the section 1 guidelines, because I want you to know that we have section 1 applies to everything, all settings. Then we have section 2 guidelines, which are applicable to inpatients. Section 2 and section 3 apply to inpatient setting. Section 4 applies to the outpatient setting. So you're going to come back and you're going to refer to these depending on what setting you're coding for. Section 2, selection of the principal diagnosis. Section 3, reporting additional diagnosis. Again, those are both for the inpatient setting. And then section 4, diagnostic coding and reporting for guidelines for outpatient services. Then we have appendix Roman numeral 1. And this is your present on admission reporting guidelines. So if your textbook mentions POA, present on admission, make sure that you come back here and refer to the POA guidelines. Again, this would accompany inpatient coding. So here you have appendix Roman numeral I. It's your basics for your POA. And then here's your reporting guidelines. So it's all part of appendix I. But that's your POA, present on admission. And again, these guidelines are found in the front of your code book, or you can get this PDF version online like I did. I think I got it from the CMS website, but if you just do an internet search, Google or whatever browser you want to use, just do a search for the official guidelines for coding and reporting, you can easily find a PDF version. And as we say in coding, guidelines, 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 guidelines. You must follow the guidelines. Otherwise, your coding is not going to be complete or it's not going to be accurate. So this is just a quick overview of some of the guidelines, but again, review them on your own and refer back to them often. Even if you give them an initial review as you're doing your coding, come back and review and review and review. Because with coding, it just takes lots of practice. Practice, practice, practice. That's another thing we say all the time. Guidelines, 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 practice, practice, practice. And that's what it takes to truly master coding. So I hope this video was helpful to you. And with that, I am going to go ahead and close it out.